Well, welcome and thank you for being part of the conference this morning. Let's start with you each telling us about yourself and your experience so far. So perhaps including your experience of speaking to a doctor about your prostate cancer risk and the PSA blood test, how you came to having a PSA test in the first instance, and any symptoms you may have had. And Tony and Junior, perhaps you can tell us a little bit about your diagnosis and treatment. Let's come to you first, Junior.
Yeah, certainly. And thank you. So I decided to go for a health and well-being checkup when I was about 50, 51. Just because I also picked up that a number of men had been having prostate cancer treatment. So I asked for PSA to be included as part of my checkup. My GP is very good. I went along and they said, yes, they'll do all of that. I had a checkup. They came back with a raised PSA and they sent me off to get checked up at the hospital. I went along to the appointment and I went through a series of tests and checkups. And subsequently, they said they're very raised PSA for my age and I should come back for annual monitoring. So I just duly followed that. Carried on having annual checkups until for 4 years. So just as I turned 56, they said to me, I need to have um, treatment because my PSA is raised again. It continued rising, but they said it got to the point where they felt I needed treatment because it was rising much faster than they believed it should. So I was diagnosed for having treatment. Before that, I'd set up during that time, so I should say, I'd set up a men's prostate cancer support group. And in setting up that group, we got surgeons, radiotherapists, various people from the NHS around prostate cancer, as well as Macmillan cancer nurses and someone from prostate cancer to talk to the group over many years. So I identified quite a bit for myself as to what are the side effects to some of the treatment, what are the treatments and what are the side effects. And so I felt I was quite informed that I didn't want to have a prostatectomy. I didn't want to have the normal radiotherapy. I decided to go down the proton beam treatment route, and that's what I had, but I paid for that privately. At the time, did I have any side effects? No, never had any side effects all the time leading up to my first PSA test. All the years going through having the PSA test, I had no symptoms, but it kept rising. And I feel lucky, I feel blessed that had I decided not to have had that checkup, I could have very, very much been in a very, very different position. So I feel blessed that I did follow, what I was understanding and learning, had that checkup, and was able to do something much earlier in my diagnosis than much later if I hadn't been diagnosed. So no symptoms for me.
Thank you, Junior. And Patrick, can we come to you next to hear your experience?
Thank you, Meg. So, I think for me, I went to my GP when I was 40. The reason for that was my father was diagnosed with prostate cancer very late in his mid 70s. And my sister had also died of breast cancer at the age of 41. And certainly the materials that I had been reading um, were indicating that I was at risk. Reading materials through prostate cancer shows that 1 in 4 Black men are likely to have prostate cancer in their lifetime. So I went to my GP quite early. And I was told at the time that I didn't need to have a PSA uh, because I was 40. But I was concerned. I was really keen that I get screened quite early. I went back to my GP 4 years later, and what I was offered was a rectal examination, which I wasn't really keen on, and I didn't go ahead with it. And so, by chance, because I chair a network of men, we invited Susan Piper from Prostate Cancer UK And she came along and talked to us about the profile study. And this is a study that's aimed at Black African, Black Caribbean men, and specifically to do research around understanding that risk. And so I was really encouraged by Susan in what she said around the profile study. So I signed up for that. And what it involved was me going down to London to the Royal Marsden, having some blood tests. And I must say, the nurses were absolutely amazing, explaining the whole process to what happens after you have your blood tests, whether you need an MRI scan, whether you might need to have a biopsy. And not everyone would need that, but certainly that's the whole pathway is explained to you. And I am pleased that I didn't get onto a pathway for further tests when I had my PSA results. But I'm delighted as well that I'm now monitoring that on an annual basis as part of the research program. So that's been my experience. And really, for me, it's about making sure that we encourage more people. I've certainly been encouraging people from Black African, Black Caribbean, to really be part of the profile study.
Thank you, Patrick. And I think we're going to put some information about the profile study. So if people want to know a little bit more about that, they can read some more. Tony, can we come to you next?
Yeah, thanks, Meg. I had my first PSA test without even knowing I was actually having a PSA test. I was 60 years old and I was training for one of the world's toughest ultramarathons. And this was in 2017. And in the February, I started with what I thought was a groin strain, which got more and more painful. And I realized I wouldn't be doing the ultramarathon if I didn't do something about it. So I made an appointment to see a sports injuries doctor, and he'd prearranged an MRI scan. He saw the scan, didn't like what he saw, and said, "While you're here, I'm sending you for a chest x-ray and some blood tests." And that was the PSA test. I didn't know I was having the PSA test. And then said, "Tomorrow I'll put you in for a full body CT scan." He phoned me the evening after the CT scan to say, "Fairly sure you've got prostate cancer. I need you to have some more urgent diagnostic tests," which included transrectal biopsy, bone scans. And it was ultimately confirmed that I was de novo stage 4. At diagnosis, the cancer had spread into my pelvic bone, which is why I was experiencing what I thought was groin pain. It was a stress fracture of the pelvis. But it also spreads in my hips, ribs, spine, neck, and skull. I'd had absolutely no symptoms at all of prostate cancer leading up to that diagnosis. And so you can imagine it was a real shock. I was given a 2-year prognosis, worst case 2-year prognosis. I'm still here 7 years on, thankfully. And treatment-wise, I went straight on to androgen deprivation therapy, hormone therapy, which removes male hormone, which has horrendous side effects, consequences. And I was due to start chemotherapy in the August of 2017, but I heard about a drug called abiraterone in the June. I got emailed by people from all over the world telling me about this new wonder drug, and my oncologist managed to get my private medical insurers to fund it for me. I went onto the abiraterone straight away. My PSA fell from 129 at diagnosis down to undetectable, where it's stayed pretty much ever since. Regrettably, abiraterone still isn't available as a first-line treatment in the UK, which I find utterly bizarre. But that's my story. Pretty one of the grim ones, I'm afraid.
Thank you for sharing it with us, Tony. And I know that you're all very involved in speaking to other men about risk of prostate cancer. And I want to explore a little bit more about some of the conversations that you have with other men and what they tell you about their experiences. Should we go to Patrick again first?
Thanks, Meg. So certainly I do have conversations with other men in terms of their experiences of going to the GP or talking about prostate cancer. We have to recognize that this is something that can be quite scary, anxiety provoking. As much as there's information out there, I think it's important that we give people the right information. So for me, I think there are some of those fears. I talked about the rectal examination. That certainly does put people off. Although there is a space for that, and it's important that people have an informed understanding of why it's important that sometimes people need to have a rectal examination. But I think it's the nature of the conversation that you need to have with individuals. And we can't have a system that's depending on luck of who is the practitioner in front of you. We need very clear guidance that's there to support individuals. And for me, the fact that I recognize that I'm in the high risk, there are other people from my heritage who are not aware of that. They're not aware of the risk, which means that they're presenting really, really late. In my father's experience, he was diagnosed really late. And I think that there's more we can do to support people to be screened much, much earlier and get appropriate support.
Thank you, Patrick. Tony, let's come to you next.
Yes, I'm one of Prostate Cancer UK's awareness speakers, and I did 50 awareness talks in last year. What is very clear is that unfortunately some GPs don't follow their own guidelines about counselling men about the PSA blood test. And so the first barrier that a man comes across is to pluck up the courage to ask the GP. And then the second barrier is quite often going to the GPs and finding out that they refuse to give them a PSA test, or that the receptionist, as in my own GP's case, said we don't do those here. So those are massive barriers that need to be overcome. It really is important that men are given all the information necessary to make a decision about whether they want to have a PSA blood test. And until we can get all GPs singing from the same hymn sheet, making sure that men can access a PSA blood test after appropriate counselling, then we will start to save more lives. It's becoming really apparent that more and more men are being diagnosed at late stage, like I was. And regrettably, not all men are as lucky as I've been to survive 7 years on first-line treatment. So I think we need to do much, much more. We need to make sure all men have the ability to make an informed choice, and we need to start doing it straight away.
Thank you, Tony. And Junior, anything to add about those barriers or challenges that men might face?
Yeah, certainly, Meg. When I set the group up to support men and to bring increased awareness around the importance of testing for prostate cancer, many of them came along to the meeting and said that their GPs would not support them having a PSA test, even though they explained that they are at risk, being 1 in 4, even though they explained that there was a father or a brother or an uncle who had prostate cancer. The GP still deemed that they weren't going to test. And I took the view within the group that we had to help them to do something about this. So we developed a standard template letter that set out in the letter that each person who wanted it could take along to their GP, saying they're in a category of men that are at risk, 1 in 4 or 1 in 8, that they have a history, a family history of prostate cancer, and so they should be checked from the age of 45 or from the age of 50 if they weren't with a family history. And that letter has been presented to many GPs in Wolverhampton and across the Black Country. But it's not enough, because we really need the GPs to be better informed and better supported. I went along to Prostate Cancer UK's first group meeting to discuss Black men's health around prostate cancer. And there was a GP there, a Black GP, and he was talking down as well to say that, well, no, testing is not appropriate. Obviously, rectal examination is possibly something that's easier and less in terms of risk of spreading or causing any harm to the patient. And many of us pushed against what he was saying from our own experiences. A bit later on, after several months meetings, he disclosed that his brother had been diagnosed with prostate cancer. And had it not been for the PSA test that his own GP had done for him, he may not have been identified. So he had a moment on the road to Damascus, so to speak, where that awakening for him was, yeah, PSA testing is important. So I'd urge all GPs to become far more familiar with it. And I say to men genuinely, when speaking about the intrusion of rectal examination, that it is a moment inconvenience to seek assurance, or for a moment inconvenience to be having earlier diagnosis and earlier treatment, and therefore possibility of saving your life.
Thank you. And I guess it seems obvious from hearing about that range of experience, but what do you think the impact is on health inequalities given that variety of experiences? Did you have anything to add about that, Tony?
Yeah, I think it's very clear that we need to do more to educate GPs in primary care. Many of them don't seem to understand that the diagnostic pathway has changed, and that it's improved, and that in the old days, prostate cancer diagnosis may have caused harm to men through overtreatment. That shouldn't be happening anymore. I'm not sure all GPs have necessarily caught up with that. And so what's happening is that some GPs basically are not following their own guidelines, and therefore we need to do more work with GPs to make sure they understand, because it's horrendous that you can go to a GP's, ask for a PSA test and be refused, and yet go to another GP's and they say, yeah, no problem at all. And I think that's created its own inequality, because some men can access the PSA blood test and many men can't. That's what needs to change.
Thank you. And can we come back to you again, Gina? Do you have anything to add there?
Yeah, I think as men, we are notoriously bad in terms of our getting ourselves checked out from a health and well-being point of view. And I don't make it the GP's responsibility that we should be beholden, that they should call us. But I think if a GP doesn't see male patients for quite a while, a simple text message, letter sent out saying, we think you should come for a well-being test, well-man's test, and open the door and just have that discussion. I constantly say to the men in the group and men that I speak to on talks, or indeed who I have discussions with around prostate cancer, we should get ourselves checked out from age 40, age 45, age 50, annual MOT. We do that with our cars. We get our car serviced. We get our cars MOT'd. We don't do it for ourselves. And I simply say, dead men don't drive cars. So if you want to keep driving your car, get yourself checked out and make sure you're fit and as well as possible, and that you can enjoy driving your vehicle. So having that well man's test is, for me, important, and the PSA should form a part of it.
Thank you. And Patrick, I come to you last on that point of inequalities.
Yeah, certainly. I think for me, just picking up from what Junior is saying about, we know that men don't tend to go to their GPs to seek support. I know that's a general statement. I think for some people that's the reality, and it doesn't take much to put them off coming back again to seek support. So I think it's important that every contact should count when you do have a patient in front of you and being able to support them. So very clear guidance, I think, is important for GPs, and also being able to signpost people. So for example, signposting people to the risk checker that's there on Prostate Cancer UK website, even though you might be 40 and you're not being offered a PSA, and being signposted somewhere where you're able to check for yourself some of the information and have an informed consent around what else you might need to do to think about your well-being. I think it's important that GPs have that information and the guidance in terms of what they can do to support people.
Really good points. And it's so important, isn't it, that men have that opportunity to have balanced conversations and to consider the pros and cons of testing. But it's also so important to know that the diagnostic pathway for prostate cancer has changed in recent years. And so that balance of pros and cons has changed too. And Tony touched on this a little bit, but, thinking about the modern pathway, the tests involved in diagnosing or ruling out prostate cancer and the management of early prostate cancer, What impact do you think these changes have when it comes to men making informed choices about PSA testing? Junior, can we come to you?
Well, to be honest, what we need about making sure men are informed is about the risk checking. But what we've been doing at Prostate Cancer since I've been joined the group is that we've actually done some targeted marketing by using names from those who are African Caribbean, those who are African descent, those who are of European descent. We've used names associated with their communities so that they can associate when they see this advertising to say, ah, this really does apply to me. And so getting myself PSA checked is something that is important for me and good for my well-being. And one of the other things that we also say is that the impact that it has on the man, and I say this to all men, is that just in case you are at risk, if you're in a high risk category, if you presented late, the options are reduced in terms of what treatments you can then have. So the earlier present is the better the menu of choice for your options, and obviously the quicker your recovery. So the whole thing around PSA testing, the whole thing about general health and well-being, and explaining it in as full a sense as possible is so important for men to understand. Don't get me wrong, there are those men who have their own suspicions if they start to have some symptoms and don't want to go get themselves checked out. And at one meeting, the very first meeting I held for the prostate cancer support group for men in Wolverhampton, we encourage women to come along because they will also speak to their men and their partners about this. And a lady came and talked to us at the end and said, I'm sure my husband has some of these symptoms, but he will not go to the doctor and he will not have his PSA checked. And that is so sad because she can then see a decline or see growing symptoms of whatever it is that he's experiencing. So we also have to strip away some of that fear and actually present something that actually what you may think you're experiencing, if we get and serve you and help you earlier, you will not lose the functionality. You will not have the bowel and the bladder problems that men fear for.
Thank you, Junior. Tony, can we come to you next? And you've certainly been through the pathway that has changed in recent years, and I think you've seen some of those changes. What are your comments about that? How that may have changed informed choice?
Yeah, I think we have a big education thing to cope with here. GPs obviously are not experts in prostate cancer. They're probably not up to date with the latest diagnostic pathway or with the improvements of treatment and the use of active surveillance for men with low-grade cancer. The improvements have been significant. You know, historic. I mean, I had transrectal biopsy 7 years ago, which is exactly what it sounds like. Things inserted up the back passage and pieces of your prostate snipped away. Those are now done transperineally under anaesthetic, much less risk of infection, and therefore much more viable. And of course, in the old days, if people used to go straight to biopsy, now there's a multiparametric MRI scan in between. So again, it's reducing the number of biopsies, which could potentially cause harm. But then the most important thing is that low-grade cancers are no longer treated or given on active surveillance where men are monitored just to make sure that things are going in the right direction, not worsening. And I think there's a whole education piece about making sure people are aware of that. And certainly when I do my awareness talks, I try to cover those changes, because people say to me, you know, why is there a problem with a PSA test? Well, the problem is all historic. We're now in a different regime where things are done very differently. And I think we just need to get that message across so that men can make an informed choice, are not scared of having a biopsy, are not scared of the diagnosis, because treatments have changed exponentially. You know, in the 7 years since my diagnosis, when I was diagnosed, basically the treatment for advanced stage prostate cancer was hormone therapy and chemotherapy. There's now about 7 or 8 other treatments available. So things have been changed massively for the better, but we do have a massive education piece to make sure that message is out there.
Yeah. Thank you. And so dispelling misconceptions. I don't know if there's anything that you can add to that, Patrick.
Yeah, I think it's making sure that people have the access to the right information is important. Uh, Through the profile study, I became aware of the different diagnostic pathways, which I wasn't aware of before. And it's because I was sitting in front of a practitioner who was explaining this with empathy uh, for me to understand and concerned to this. And I don't think when men have been in that position of privilege, having someone explaining this to them, they rely on what they see on the internet, which I think is quite risky. For me, I would want to see men at a certain age where they've got a constitutional right to have this conversation with a professional and be informed around the different diagnostic pathways.
Thank you. And something that gets often mentioned in relation to prostate health and prostate checked is the digital rectal examination, the DRE, or as men will often say, the finger up the bum test. And that's another change because we know that the DRE is not a good way of finding prostate cancer for men who have no symptoms. The PSA test is a better indicator. And this latest consensus recommends that GPs don't need to do a DRE for asymptomatic men. If the PSA is going to be 3 or above, they're going to be referred for further investigation, which, as Tony said, is now an MRI scan. And that's going to be a much better way of assessing the prostate, better than a DRE ever would be. So that isn't going to be the first test that a man's going to be talking to the GP about if they're asymptomatic. I'm guessing that you probably think that this is a positive thing both for men and GPs. Patrick, can I come to you first?
I think it is positive, but it's ensuring that GPs have that information. Certainly, in my experience, that's what I was being offered. I wasn't offered a PSA, even though I'd been to my GP for a number of years, and it's taken 6 years to actually have a PSA test. So I think it's important that we have the guidance very clear to GPs and also to individuals so they know what to ask for when they go to their GP. Because most of the time men go to their GP and they don't know what to say or what to ask for. But I have spoken to other people who've had rectal examinations, and of course, the conversations that they have with other men, they're very discouraging in terms of their own experiences. So we want people to have a positive experience of going through a diagnostic pathway because that enables others to go and do the same.
Absolutely. Thank you. Junior, anything to add?
Yeah, it is all about that experience, and to be honest, I understand GPs offering to do the rectal examination, but they're not a consultant or a specialist in that area, and so I do encourage men to ask for the MRI scan. PSA test initially, but an MRI scan, just because once that's referred, that identifies any potential issues without intrusion, and it's far more precise as well. That will also help if there was a need for a biopsy. It is far more precise and far more helpful. So I think there is this whole awakening. There's this change in space, and there's increased attention that through a number of high-profile figures who some are with us and some are no longer here, who have raised the flag around prostate cancer, are helping to bring awareness to men. And I think it's beholden to us all to keep flying the flag and making that noise in order to increase awareness and to get men checked early. I'm all for the early screening because as someone who's partially involved in the NHS, when we present too late, we cost the NHS more money. Just looking at it from the cold financial statistics, far more helpful if people present early, get a sense of general health and well-being. Symptoms are picked up earlier, if at all there's any symptoms, but we can then help that person with their recovery far easier, far quicker, and far cheaper to the NHS.
Thank you. And Tony, any last thoughts on the DRE?
I think it's a positive. If it puts men off going to the GPs, then it's got to be a positive. But I think there will always be a place for the digital rectal examination for symptomatic men, because some men don't emit PSA. So the DRE will be valuable in those circumstances. So I think when I do my awareness talks, I always say it's 30 seconds of discomfort. Just get over it. It might save your life. So yeah, I think it's a positive if it puts some men off, because those men can then go and get themselves tested.
So lastly, we're coming to the end now. And if you could each offer one take-home message to healthcare professionals working in primary care, what would that be? Can we come to you first, Patrick?
Yeah, sure. I think for me, my message would be every contact counts, and professional curiosity is really important to advocate for those who experience inequalities.
Great, thank you. And Junior, let's come to you.
Yeah, certainly from my perspective, my one plea to the primary care sector is that we'll have so much information about the population of people and the health inequalities that exist in our communities. And so my one plea would be that if you've got a high proportion of men in your community, your population of patients, and you don't see them very often, please contact them, invite them in for a health and wellbeing test, and include PSA as a part of that.
Thank you. And Tony, let's come to you.
Yeah, my message to healthcare professionals working in primary care would be to think more about the harm of late diagnosis. We hear quite often about the historic harms caused by early diagnosis and overtreatment, but we very rarely hear about circumstances like mine, where I face effectively a premature death, and have to live with some of the awful treatment side effects involved with now 7.5 years of 2 forms of hormone therapy, taking away my manhood and everything to do with my day-to-day existence. I believe it's probably cost something like £300,000 to the NHS and my medical insurers to keep me alive so far. That's going to get worse as my health continues to deteriorate. So please give some thought to the consequences of the harm of late diagnosis, because early diagnosis has much better outcomes where men can be curable at much lower cost to the NHS and much lower cost to the man and his family.
Thank you, Tony. And thank you, all of you, for the time that you've given and sharing your experiences. It's been a really fantastic conversation. And I think, to wrap up, the take home would be the importance of this balanced conversation, considering the pros and cons, finding the opportunities to have these conversations, using the resources to help empower men with the information that they need. That PSA is a better indicator than a digital rectal examination, and for men that don't have any symptoms, the DRE may not be necessary. And the improvements in the pathway that we've seen. So an MRI scan becoming the standard of care for men that have a raised PSA, so that some men won't need biopsy. Those men that do need a biopsy will have a much safer transperineal biopsy. And the improvements in the way that we manage men with early prostate cancer as well. So some fantastic points there, a really brilliant conversation. I'd like to thank you all again.
Thanks, Meg.
Thank you.